Hi, this is Oleg Borisenko and Market Access Insider channel. In our programs, we discuss organization and financing of healthcare services and medical technologies in European countries. Today we're in Prague, Czech Republic, and we're going to talk to Pavel Hroboň, who is the managing partner at the Advanced Healthcare Management Institute. In this video, we're going to cover a broad range of topics, including organization and financing of healthcare services, role of DRG and health technology assessment in Czech Republic. Hope you'll enjoy the program. Thank you, Pavel, for talking to us.
Thank you for the invitation.
Can you start with a general overview of Czech healthcare system?
Absolutely. I'll start with funding. We have a system of statutory health insurance, which, in many features is similar to Germany. There are some important differences, but for the beginning, we can start with the shape of the German system. So we have several insurers which do compete to some extent. There is a free choice of insurer. We have currently 7 insurers. As is the rule and the habit in statutory health insurance systems, all of the insurers have to cover the same range of services, and they have actually to charge the same price, which means people pay the same amount, namely 13.5% of their gross salary, which goes towards health insurers.
All right.
That's for the funding side. Then on the provider side, I would say that we are a typical Central European system with many hospitals, with quite a high number of beds, frequent hospitalizations. The length of hospitalizations has actually been going down considerably in the last years, but still is one of the longer in Europe. And regarding the outpatient care, again, as in Germany, we have both primary care physicians and outpatient specialists.
All right.
As opposed to Germany, we actually have 2 parallel systems providing specialized outpatient care. The first one is what I've already mentioned, offices-based specialists, but also hospitals do provide outpatient specialized services. So I would say that in terms of geographical access, in terms of waiting times, we are doing pretty fine, at least so far. The future might look differently because the average age of physicians is quite high in this country, and we are already now experiencing personnel shortages both on the physician side and on the nursing side.
All right. And who are the main regulators of healthcare system at national level? Like Ministry of Health?
It's certainly Ministry of Health. Ministry of Health plays a very important role. It's the general regulator responsible for legislature, of course. There are several specialized institutions, like the State Institute for Drug Control, which is responsible not just for registration, but also for reimbursement of pharmaceuticals. And recently it has got a role in registering of medical devices as well. And the ministry has got quite a few powers in overseeing the insurers, and also the ministry has a big role in price regulation, not just pharmaceuticals and medical devices, but also medical services provided by hospitals and other providers. We have collective negotiations between payers and between providers, but in case they do not arrive to an agreement, it's up to the ministry to decide. Right. And the last piece, which makes the ministry, I would say, extraordinarily strong compared to at least most European countries, it's that the ministry directly manages and is responsible for most of specialized hospitals, basically all the teaching hospitals, plus several other highly specialized institutions.
All right. And so you mentioned statutory health insurance. What's the role of private health insurance, if any?
The private role of insurance is truly marginal.
Marginal.
I think that the main reason is that the range of services which are covered by the public system is actually very broad. And also, at least in the last 20, 30 years, and namely in the last 10 years, the real accessibility of services is pretty satisfactory for most of the population. So this is the main reason why private supplementary insurance didn't really take off.
All right.
Again, maybe different in the future.
Mm-hmm. So can we move to the overview of the financing model in the healthcare system?
Absolutely. From a tech point of view, probably not so important how general practitioners are paid, but it's a mixture of capitation and mixture of regulated fee for service. Mm-hmm. In case of outpatient specialists, it's a regulated fee for service. Mm-hmm. And by regulated, I mean there is a regulation on the volume of care they do provide, which is based on average volume of care which has been paid for 2 years ago per average patient. Mm-hmm. Plus, there is also regulation on prescribed pharmaceuticals, medical devices, and also care which has been recommended to be provided by other providers, of course, including laboratories and imaging methods. The second part of the regulations is not too strictly applied, or better said, in case the overall budget of the health insurer is kept in line with the plan, then these regulations are not applied, which was the case in the last 5 years, because the economy has been growing very nicely. So there was a sort of continuous growth of available money in healthcare. The first regulation I have mentioned, which deals with the care provided directly by outpatient specialists, is applied much more strictly.
Mm-hmm. And what's the payment model for hospital care?
As for hospital care, we have DRG-based budgets. Mm-hmm. In reality, this means a budget of a hospital is again determined by what has been paid to the hospital by health insurers in the reference years, which means calendar year 2 years ago. But to get this money, hospital has to sort of provide a case mix, which again is comparable to 2 years ago. If the actual case mix is lower or significantly higher, then there are some adjustments. Mm-hmm. Plus, some sorts of care has been carved out from this main DRG-based budgetary system. And probably the most important of these carve-outs are so-called center drugs, which are highly innovative modern drugs like biological drugs. And hospitals do get special budgets. Not all of them. This care is centralized, but for hospitals which have been put on the centers list, they do get special payments, special budgets based on number of patients they treated, their diagnosis, and some developments in the area in terms of which new drugs have arrived to the market and which ones got generified.
Mm-hmm. Are there any supplementary payments for procedures, I don't know, like dialysis or extracorporeal membrane oxygenation, something also very expensive? Or is it...
There are some of them. There are some other smaller carve-outs which do include payment for HIV patients, mm-hmm. which do include patients with hemophilia, mm-hmm. And some care is provided without the volume cap. For example, birth and care provided to the newborns, because there is sort of a fixed number of births in a country in a given year. So it's paid basically per case basis.
All right. But for other healthcare services, it's all global budget adjusted for case mix?
Yes, with the exception of some services which are provided on outpatient basis, so like hemodialysis.
Fee-for-service model. All right. Are there any specifics in relation to teaching hospitals that subordinate directly to ministry, or is this?
Well, yes and no. There is no specific which would be clearly defined. On the other hand, the budgets I have mentioned are actually based on two factors. One of them is case mix, which means number of patients and severity of patients, of course. On the other hand, it's based on historic payments. And historic payments used to be higher for teaching hospitals.
All right.
So there is a systematic difference between more specialized hospitals, to which teaching hospitals obviously do belong, and less specialized hospitals. But there are also other differences, even in the group of teaching hospitals or in the group of less specialized hospitals. You have some differences in unit reimbursement, which resulted from the past. The ministry has got some plans to address this issue, but we'll probably touch upon them later.
So what's the mechanic of budget allocations? Is it happening at the beginning of the year or quarterly?
We are talking about annual budgets.
Yeah. Exactly.
First, there is the collective negotiation between payers and providers, which starts sometimes in May and is supposed to finish in September. And then in October, the ministry issues so-called reimbursement decree, which states in a lot of detail which is the default solution. And then individual providers and individual payers can agree to a different payment mechanism or to some exceptions if this is in line with all the regulations, of course, and also with financial plan of the payer. And this does happen in some cases. In some areas it is less frequent, in some areas it is more frequent. So finally the contracts or better said, contract amendments for a particular year are being closed usually in the first quarter of the given year.
All right. And what happens if hospital runs out of the budget? So let's say they didn't plan well. So what happens then? Let's say if money ends in, October, November, do they get some extra budget from the...
There are two ways. Either the hospital can argue with changes in the range of provided care, and also including some innovations. But this should ideally happen before the final budget is set. Of course, there are frequent negotiations and discussions between hospitals and payers, also in time when the annual budget is actually finally cleared, which means around April, May the following year. But generally speaking, there is no general reserve or general special money which a hospital would be entitled to if it misses the budget. Then it's up to the founder of the hospital, which may mean of the government in case of teaching hospitals and specialized institutions, which means regional governments in case of most hospitals in the Czech Republic, and which may mean also other public owner like a church or like a town, may mean also private owners.
All right. Can we now move to the topic of DRG? So what's the history of DRG in Czech Republic?
Well, we've got a long history of DRG, but there has been a lot of hesitation before truly introducing DRG as the primary classification mechanism for acute hospital care and also as a basis for reimbursement. So we have finally introduced DRGs like 10 years ago. But as I've already mentioned, the introduction of DRGs did not mean that all hospitals are paid the same unit price. So there are systematic differences between more specialized and less specialized hospitals, and there are also sort of random from the past resulting differences in base rate between hospitals which provide comparable services. The Czech Republic is still using the IR-DRG, but in the last 3 years, a big project has been going on, which actually has been putting together CZ-DRG, which is sort of a bottom-up prepared new DRG classification. It's being finished this month, and it is expected that the ministry will come soon with a strategic plan how to implement CZ-DRG. And there are, of course, as always, high hopes for higher clinical precision, and also for leveling the field, which means getting the base rates of different hospitals closer together.
Mm-hmm. Yeah, very interesting. It's not very common, right, to develop your own DRG system. It's not that many countries do.
That's true. Personally, I believe the decision should have been to localize DRG system which has been already developed, like the Slovak Republic has adopted the German DRG system. The decision has been different in case of the Czech Republic. On the other hand, if we look at the shape of the new classification system and on the directions in which it is heading and in which it is different from the old IR-DRG, it's pretty well comparable with the development of the French or of the German DRG in the last 10 years.
Mm-hmm. All right. So, and then if we speak a little bit more about current DRG system, who is responsible for supervision of it?
There has been an entity which has been founded by the insurers called National Reference Center. Some hospitals were participating as well as the Ministry of Health, but the main responsibility was there with the insurers. This organization has recently merged with another one, which is responsible for cross-border care settlement, and so it's still in the hands of the insurers. But the new classification I've mentioned, CZ-DRG, has been developed by the National Institute of Health Statistics. So this is where basically the responsibility for not only development but also operational management of the DRG classification has been moved.
Mm-hmm. And what are the procedural classifications that are used right now as part of IR-DRG, but also in the new DRG?
This is, frankly speaking, a weak point, because the classification of procedures linked to the Czech version of the IR-DRG is the checklist of procedures, which has been originally created for reimbursement of outpatient care and potentially also hospital care. We had a brief period in the 1990s when hospitals were paid on a fee-for-service basis. And to cut it short, this classification is not up to the task. This is a reason why a new classification of procedures has been introduced in parallel with the new DRG system, inspired mainly by the French classification of procedures. And now it should be introduced for the purposes of coding of acute hospital care together with the new DRG system.
Mm-hmm. Yeah, very interesting. I mean, obviously all countries handle this differently with classifications. And for example, in Belgium and France, it takes a really long time to introduce new codes because also price negotiations involved for the development. So it's a very interesting development.
Well, I'm glad I'm hearing that it's not a problem just in the Czech Republic, because I believe that it's truly a problem when classification of procedures serves in the same time as a classification and as a basis for reimbursement. Mm-hmm. I believe these two purposes should be separated, because then you can have new procedures entering the classification rather automatically. B, for reimbursement, it's better to have an aggregated level. And I understand it takes time there to negotiate between payers and providers, but the two purposes should be separated.
Is there any single document that determines what is guaranteed to Czech population from the healthcare system perspective?
Not exactly. There is a general definition in the law, and then there is a list of procedures. But it's been clearly stated by the Constitutional Court several times that what the services covered may be determined only by law. And the list of procedures is not a law. It's something which is under law, like a ministerial decree. So it cannot serve as a basis for what is reimbursed and what is not. But in 99% of cases, it actually does, because it covers most of covered. It includes most of covered services, but strictly legally speaking, it is not a list of covered services.
All right. And what's the process to introduce a novel procedure into the list?
The list is managed by the Ministry of Health, and there is quite a clearly described and managed procedure. And the subject which is to come with a proposal of a new procedure is the professional society, which means if you want to get a new code into the list of codes or list of procedures with a new technology, you have to get into talks with the professional society. The professional society can then make the official application. This is being reviewed by the ministry and also, most importantly, by the insurers. Which means it's basically a dialogue between professional society, which also represents the industry in this case, on one hand, and the insurers on the other hand. And the role of the ministry is, to help the parties to get to a compromise.
And what are the timelines approximately?
I would say that in best case, it takes about a year and a half. Because the ministry used to update the list of procedures just annually, usually since the beginning of the new year. I mean, there's nothing in law which would dictate that the list of procedures cannot be updated more often. And occasionally it has happened that it has been updated more often than once a year, but the usual period is 1 year. The negotiations usually take about a year. So if we cut year and a half, we get to a year and a half of time from the start of negotiations, better said, from the proposal being submitted to the new procedure appearing in the list.
And what's the rationale for determining the reimbursable amount? Let's say if it's, for example, if this procedure is connected to outpatient services, because in inpatient it would be then part of the DRG. But for outpatient, so is there any particular method or?
There is a methodology with which the list is created and there's relative weight assigned to a new procedure. So obviously times needed for the procedure to be performed, list of physicians, nurses, other healthcare professionals who participate has to be submitted, plus other costs for material, etc. Obviously, also the number of patients, the number of expected procedures, and then there is truly a haggling with the health insurers over the different parts and points. So it really depends on what's the general financial situation of the statutory health insurance system.